Hi, I'm Dr. Janet Pope. I'm at Janet Bordeaux, and I'm reporting for At Room Now, and this is live EULAR Copenhagen 2022. I wanted to talk about COVID, so I've called this session a little bit on COVID insights, and then also should we hold methotrexate when vaccinating our patients? And I think it's generalizable to vaccines beyond COVID. So what do I want to talk about? So there were two randomized controlled trials of holding methotrexate after COVID vaccination versus not holding. The first one's a late breaker, abstract LB0003, and the second one is poster 0259. The first trial was in RA and PSA. And what they decided to do was hold methotrexate after both COVID doses for 2 weeks versus not holding. That was 250 patients. The second thing they wanted to do is if you already had a COVID vaccine, what about holding for one vaccine and not the other? So the first dose wasn't held, it had already occurred, so methotrexate had already been given, but the second dose, 2 weeks of methotrexate was held. So that had 178 patients. So I'm talking about in this one, two randomized controlled trials. So what they find, they found in both cases, if you hold methotrexate for 2 weeks after any COVID vaccination, you get higher antibody response. But if you're holding and it's only 3 to 4 weeks apart for 2 weeks, you have more flares. However, if you're just holding for 2 weeks, you already got your first vaccine, now you're into your second vaccination, or frankly, third, fourth, or in US right now, the fifth vaccine, if you hold for 2 weeks after, you do have higher antibodies and a similar flare rate. But if you're holding frequently when you're doing your initial vaccinations, there are more flare rates. But this and the other randomized controlled trial I'll talk about, we don't know if an attenuated antibody response translates into more severe COVID. However, in influenza, the same thing was found. If you hold for 2 weeks after getting your flu shot, you get a better response. Does it translate there into clinical care? Who knows, of more severe infection or more often infection? Don't know. But why wouldn't we want our patients to get the best thing possible? So does it change my practice? Well, we'll see. The second randomized controlled trial was RA patients well controlled. RA, CDI less than or equal to 10, and low dose prednisone was allowed. So they looked at one dose and then the second dose of a COVID vaccine. And in this case, it was one that we don't have in North America, Sinovac, Coronavac. So that's what they were looking at. And they evaluated a month later and also at day 69. So if you withdraw methotrexate for 2 weeks compared to continuing, you had a seroconversion rate of 78.4% versus maintaining methotrexate at blunted seroconversion 54.5%. This was strongly statistically significant. The p-value was less than 0.02, but here's the downside, more flares. So putting these two things together, what's the take home? Number one, for future COVID vaccines, I will probably ask patients where possible, hold methotrexate, and I'll generalize as well to hold conventional synthetic DMARDs and probably advanced therapies for 2 weeks if possible after the vaccine. If you're flaring, just go back on it. Better to go back on your drug than to use prednisone. And if you're getting other viral vaccinations, so shingles vaccine, flu shot, I'll probably say the same thing. So I think we have a take home. I think these trials are helpful and this will change my practice. So follow us at Room Now and we'll give you more great advice and information. Thank you.